With your hosts, Lily Mundy, Raj Parikh, and Kyle Sanniec, this is the award-winning PRS Journal Club podcast.
Hi everyone, and welcome to the September 2019 edition of PRS Journal Club podcast. I am Kyle Sanniec, PRS Resident Ambassador from UT Southwestern, and I am joined by my co-resident ambassadors, Lily Mundy from Duke University and Raj Parikh from Washington University in St. Louis. Today we have the honor of being joined by Dr. Scott Hollenbeck, plastic surgeon and associate professor of surgery at Duke University. Thank you so much, Dr. Hollenbeck, for joining us for this PRS Journal Club podcast.
Thank you. My pleasure to be here.
The articles that we will discuss can be read for free on prsjournal.com, including an archive of all past journal articles. The article we will be discussing today is Timing of Microsurgical Reconstruction in Lower Extremity Trauma, an update of the Godina paradigm by Dr. Levine's group out of NYU. The goal of this study was to update Godina's landmark study on lower extremity reconstructive timing and outcomes. The authors performed a retrospective review of all lower extremity free flaps for trauma patients. The authors stratified patients based on Godina's original timing of flap coverage, early within the first 72 hours, delayed in that 4 to 10 day range, and then late in the 10 to 90 day range. The authors then looked at the outcomes of reconstruction. In total, 358 patients met their inclusion criteria. The authors then divided the patients into an early era, the 1976 to 1996, and then a late era from 1997 to 2016. This late era corresponded to the introduction of the wound vac to their institution and showed that before 1996, a majority of flaps were performed in the early window or in the late window 90 days out, adhering to Godina's classic teaching. However, from 1997 to 2016, there was a trend for more reconstruction to occur in the delayed time frame from 4 to 90 days. They found no difference in flap failure rate, partial flap failure rate, takebacks, or overall complications when they compared the flaps performed early to those performed in the 4 to 9 day window. However, there was a significant difference in failure rates and complications when comparing the 4 to 9 day group with the 10 to 90 day group. In short, flaps performed within the 10 day window had a significantly decreased rate of major complications. So I chose this article because lower extremity reconstruction timing seems to be something that we all go back to the Godina classic article and that Godina paradigm. And whenever you're asked a question about it, it's always, in the first 72 hours is what the Godina paper says. And there's always a but with the advent of all these new techniques, the new microsurgical techniques we have, that's probably not adherent to that timing. So I like this article because it did actually give us some data to expand the timing of our reconstruction window with the advent of the wound vac and the improved micro techniques. Overall, I thought this was a good article. The fact that they broke the timing of reconstruction up between when they started to routinely use wound vac certainly helps lend credence and support the view on expanding the reconstruction window to 10 days with all these new technologies we have for managing lower extremity wounds. Although I do wish they would have had a more long-term outcome study, especially with some of these kind of lower extremity wounds that have partial dehiscences, or it kind of takes a while that you take them through 90 days in your clinic before they have some long-term outcomes, say at like a year. That would have been interesting to see what the final result are in terms of getting patients back to ambulation, back to work, are they able to wear regular shoes, etc. So with that, I wanted to turn to Dr. Hollenbeck and say, what did you think of this study?
The study I read with great interest for a couple reasons. Number one is it's a very large study. It includes a large number of patients. I believe it was 358. And I also was interested because I know the group that is doing the study out of NYU, and they have done many studies. And so I followed their work with interest for years. And in fact, I saw this work presented at a recent conference. So I was very interested to see this. Probably the take-home point is exactly as you described, and that is timing of reconstruction. And as you mentioned, there's been a paradigm in place for a long time based on the work of Marco Godina, which basically said that within the first 3 days you need to get to the OR and get the open fractures covered, and that patients would have a better chance of healing and having successful bony healing, most importantly. And this paper begins to expand that time frame, which has been discussed amongst surgeons for years, that in fact within the first 3 days is not that practical, because many patients come as a transfer from another hospital and they've already been there a day or two, or a number of patients are sick from other things like head injury or abdominal organ injury, and you have to wait. until they're stable. So many of us have known that anecdotally that it's okay to do these flaps out of the 3-day window, but this study helps kind of prove that with some data. The thing that's interesting is nobody's really defined how far out you can go. We all know that the farther out you go from the time of injury, you get into a heavy inflammatory phase, and the success of the surgeries is much harder and much less likely. But nobody really had a date on that, and so here we're given the day, a 10-day as a time frame, that after the 10-day time mark there seems to be a much higher rate of flap failure. So that's helpful, I think, in terms of defining the days, exactly like you described there. The things that are a little less than satisfying when you read this article is that the time frame of these patients is so extensive. It's 1979 to 2016, and that's pretty rare to see a study in free tissue transfer that is, that long. And the reason why that's so unusual is that microsurgery's advanced so rapidly over the past 10, even 20 years, that going back now 30 or 40, 50 years, it almost is questionable in terms of what exactly the surgeons were trying to do at that time as they were innovating this whole field. And it's hard to compare those kind of patients to those done in 2016. Just for example, the microscopes are just totally different than they were. So that's one concern, but the authors tried to deal with that by breaking them up into sort of a modern era and an older era. The other thing that is difficult to handle when reading this is that we all know there's so many other factors besides timing. Injury severity can be totally different. The way in which the surgery was performed, was it done by the same attending, a senior attending, a junior attending? Was it done primarily by residents, fellows? Those kind of things come into play, and then concomitant injuries and other things. So that's hard to know and hard to control in a big study like this with a highly variable patient population. I would point out that we have, from our institution, we partnered with Penn, and we recently published a paper where we found that the number one predictor of lower extremity flap thrombosis was platelet count. And if the patient had an elevated platelet count over 415,000, we had a much higher, about a 4 times higher risk of flap failure. So I would argue, and I've actually talked to the lead author of this study to look at their data and see if they could corroborate that finding that we had and say that whether platelets had an impact. And I think in the end, platelets are probably just a marker of inflammation, which is perhaps also related to time. So it's all tied together, but I like having a little bit more concrete number to follow other than just day 1, 2, 3, or 4. So I would argue that as we take this paper in and digest it, that we also push ourselves to think about other markers besides just the traditional time from injury, things that are more specific. So I'll open it up with those comments and see what the rest of the group has to say.
So I was wondering, this is a little more on the multidisciplinary care of lower extremity trauma, but when in your practice are you typically seeing the lower extremity trauma patients? Is it all referral based? Are you getting consults initially when they're in the emergency room with a trauma? Obviously it's a little different if you're getting referred from an outside hospital, but in general, when you're seeing patients in a trauma hall, are you there injury day 0, or are you getting called day 2, day 5, day 7? Where are you getting involved in the reconstruction process?
Yeah, that's a great question, and it's incredibly important. And let me just clarify, I think I misspoke earlier when I said the number of patients. I think this study was actually 806. I miscalculated that as 358, but 806, so that's a large study. But anyway, to your question, when do we as plastic surgeons, reconstructive microsurgeons, get involved? Well, the sooner the better, and it's variable though. It depends on who's on call, which orthopedic attending's on call. Do they have a good relationship? Do they know you? Do they trust us to call us? It depends on us. How do we respond to that call? Do we say, call us back when the wound's clean, or do we say, yes, we'll be there, and we come in the middle of the night? The thing that's gotten difficult is just with so many pressures on our time and efforts that it's very hard to be there at the very initial debridement with orthopedics, because the idea is orthopedics is doing it, and so why do you need to have 2 teams there? Why do you need to pull more people into the hospital who would otherwise be home resting or studying or something? So that has been my observation over the years, that it's more of a orthopedics at the beginning, and then they notify us when it looks like they're going to need our help for closure and it looks like they're going to need a flap. But I am a strong advocate of being, involved from the beginning. In fact, there was a time where it was part of a page that went out to everybody, including the plastic surgery team, to come to the emergency room and evaluate an open tib-fib fracture.
So that kind of leads me to the next point is, how would you suggest that as plastic surgeons we can reach out to orthopedic groups, specifically if we're not coming from a center where that relationship is strong? Any suggestions or tips you can give us to how we build those bonds of getting those patients taken care of in a multidisciplinary fashion?
I think this is true for many areas of plastic surgery, and you'll hear this from a number of different people, that basically we provide a service for people, and like it or not, sometimes it's unpleasant to provide that service, meaning it's late at night, or the patient is difficult, or the patient has suffered many different complications. That is part of what we do, and we take problems that other people are having in many instances, and we try to fix those problems. That is one of the essence of plastic surgery. And so the number one thing is, when somebody calls you for help, you have to respond in a way that is positive. Yes, I will help you. And then you have to deliver on your promise. You need to be on top of things. You need to handle the patient, the family, such that a lot of the concerns are directed to you and not to your orthopedic colleagues when they're busy doing other things. And then you need to take it to completion and stay with the patient, and then the patient will go back to your orthopedic referral or whatever we're talking about and speak highly of you, that you did a nice job and that you were a nice person and that their family liked you and that you followed up on things. That's how you maintain a relationship once they reach out. Now, to start a relationship out of the blue is a little more challenging, but basically it starts with a conversation. And so you can reach out to your colleague and say, hey, I'm new in town and I have an interest in lower extremity trauma care, and would you like to grab a coffee or something? And you just simply show that you're interested and that you want to be a part of it. And then you get a sense from your referring surgeon what they need from you. I don't need you to come to the OR the first night, but I would like for you to come see him the second debridement, or whatever it ends up being. And then you start that cycle of, okay, I'll take care of your problem and I'll deliver on what I promised. And once you do that once or twice and make their life better, their life easier, your practice will take off.
Raj, when are you guys getting involved in Reconstruction at WashU? Is it along the same thing where you're just getting called whenever there's an issue, or are you getting there, from the ground floor when they come in the trauma hall?
So we get often called, just like Dr. Hollenbeck said, after the initial fracture management. And oftentimes, a large part of our traumatic lower extremity population are referrals from outside hospitals where they're either stabilized and treated, the fracture stabilized and treated initially, or sometimes they have multiple operations before they're sent over and before, they need wound coverage. So we are usually seeing these, it's very rare to be able to get to them within 3 days, like Dr. Godina had initially advocated. So I think that's what I really enjoyed this article for. I think it is a much more practical approach to get to them within a week, even up to 10 days. So we're seeing them, I'd say probably day 4 or 5 is usually ideally when we're called, but that doesn't always happen. I mean, sometimes it's a week. And then, frequently if they didn't get an angio, if there wasn't concern for vascular injury at the time of their presentation, and we do formal angios in all of our traumatic lower extremity population, that's just a preference. So, getting a formal angio takes a day. So it takes time often to get these patients into the operating room. And then the other thing that Dr. Hollenbeck mentioned that I think is 100% true at most centers now is that it's just the time burden and the pressures from the operating room. Unfortunately, the reality is financial, and a lot of these patients are not insured. The hospital is not incentivized, unfortunately, to take care of them kind of in a rapid manner, such as if it was a spine injury or something like that. So getting the time to do these cases, often we're having to use the orthopedic or trauma block time that they have to do these cases, just because, we don't have set aside time, and you can't keep open time available because we don't know when these injuries are coming.
I think those are great points, Raj. Lily, what did you think of this article? I'm curious to hear your thoughts.
So I think we've had a really great, really great discussion of it so far. I think it obviously trying to, sort of expand that 3-day window is a little bit more practical. Obviously, a lot of these patients are coming in with really contaminated wounds and require multiple debridements and, are polytraumas. They have other injuries that need to be dealt with in a more acute fashion. And so kind of thinking of the time work framing in this model of, when are we as plastic surgeons kind of picking the correct time to operate, I think is like a little simplistic, because often these patients just it's so multifactorial, and so you're not necessarily choosing between day 7 and day 10 or between day 3 and day 8, but there's just a lot of other factors that you're dealing with. So it's nice to just sort of recognize what the increased complication rates might be with a later operative date, but recognizing that that's really reflective of a more complex patient that, may have had a greater severity of their polytrauma or greater degree of contamination, in addition to just, increased baseline level of inflammation that, increases with time after their injury. I think some of the limitations to the paper, which is kind of something that you would want out of a single center study, would be that they didn't really include a lot of characteristics of the wound preoperatively. We don't know how many of these patients had large soft tissue defects versus some of the later patients may have initially had healed wounds that broke down from multiple factors or had a non-union or osteo, and that's why they had a delayed flap. We also don't know some of the important postoperative outcomes like their rate of bone union or their time to weight bearing, or, not just acute flap failure concerns, but also how many of these patients proceeded to have an amputation after their attempt at reconstruction, even if their initial flap was successful. So I think, as we've sort of mentioned, it's nice to think that there's sort of a relaxation on that 3-day window up to 10 days, but I think there's a lot of unanswered questions and kind of missing data points that could have given us more insights into this.
Yeah, I think you bring up great points, and there's a discussion that Dr. Levin actually brings up to this article, and he specifically mentions the missing data points and how the next step he hopes is that these authors look at, now that we know all this information as plastic surgeons, as lower extremity salvage surgeons, is moving it on to the next step in terms of both patient-reported outcomes, but also getting the word out there so we are getting the information kind of sooner and we're seeing these patients in a multidisciplinary fashion. I think lastly, Dr. Hollenbeck, any imparting words you have for all of our listeners out there in regards to lower extremity reconstruction and your thoughts on that in this article?
I think the message is that lower extremity reconstruction is not easy, and it does have the highest rate of flap failure in all the types of microsurgical flap reconstruction that we do. And most large data sets point to about a 10 to 15, even higher rate of flap loss. So if you embark in this type of work, you are going to have some setbacks and some failures, but the reward is quite valuable, I guess, in that you can help a patient get through this and sometimes be able to walk again. And the goal of lower extremity reconstruction, I often ask students and things, what's the goal of lower extremity? And it really is, in my opinion, can be summarized as painless ambulation. And it sometimes doesn't even involve doing a free flap or even doing reconstruction. Saving a mangled leg that is extraordinarily painful does not really help a patient. Having a non-union or a malunion that requires 5 different surgeries over the next 3 years sometimes, is not helpful. So there's a role at times for amputation. There's a role at times for heroic measures, including replantation, other things. But in general, your goal is to get the patient to walk, and that might even be with a prosthesis, and hopefully they're not in pain, hopefully they're not addicted to opioids, and hopefully they're not unemployed. Hopefully you can get them back to a normal life. But it's very challenging. The best thing by far is to do your anastomosis out of the zone of injury. That sometimes requires thought in terms of how you design your flap. I would encourage everybody to look at platelet count. When we encounter a patient with a very high platelet count, 500,000 or so, and we need to do the free flap, we will use either Plavix if we have the option ahead of time. If we don't have the PO option, we will, in some extreme cases, use Integralin or other IV antiplatelet therapy, which can sometimes get you out of trouble intra-op if you're having an immediate arterial thrombosis. That often is a sign of platelet dysfunction. And if you're in that situation, you can sometimes use integralin to get out of that. It will cause quite a bit of bleeding, so you have to be careful. The patient cannot have other concomitant injuries like a head injury or liver hematoma, things like that would be contraindications. But that has helped me on a couple of occasions. But often if we see a patient like that, we'll wait and try to somehow let the platelets come down, let the inflammatory state come down, and then get them to surgery.
I think that's a great point, that the idea of a painless ambulation as the goal of all of our reconstruction should be kind of the new way that everyone thinks of lower extremity reconstruction. We can do the coolest flaps in the world and they work and they look great, but at the end of the day, a year, 2 years of this patient's life are there, and if they're still hurting when they're walking, they're not getting back to work and function, then we really did it all for no reason, unfortunately. So I think that was a great point. I think with that, we will end the discussion of this article. Thank you, everyone, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us on the Apple iTunes Store. Also, remember to tune in to the other 2 articles that we'll be discussing on this month's podcast. Finally, please join us for our monthly journal club on Facebook, where we'll be able to interact directly in real time with this month's selected article's author. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not done so already. It is there where our monthly journal club takes place. And once again, thank you so much, Dr. Hollenbeck, for joining us.
My pleasure. Thank you.
Thank you for listening to the award-winning PRS Journal Club podcast. Be sure to read all of the articles being discussed, including some of the classic pairings from the archives, for free on prsjournal.com.